Okay. All right. Welcome, everybody. Today, we want to talk about the future of quality. Like, if we have to keep doing this quality thing, how can we make it better? How can we make it work? How can we use data and standards to make quality data function at every step of the process? There is a lot to improve, and I feel like we can use new data flows to do this better. And we thought, what better way to do this than to have a provider that understands some of the provider pain? Like I understand how Providence deals with quality measures and the pain behind it. And then we have Linda Michaelsen from United, who understands it from a payer perspective. And then we have Ann Smith from NCQA that understands from the measure authority and creating the measures and the last submission step. And we thought we'd be able to give you a rundown of like where things are going in the industry. Just feel free to stop and ask questions. A lot is moving and changing in this space very quickly right now with some of the health tech ecosystem conversations, but we feel like this is an exciting area with a lot of momentum and change. And I feel like there's a lot of opportunity for leadership for folks to do this for the first time and show others how to get it done. Okay. All right, so quick agenda. Um, Quickly, what's wrong? The current data flows. We're going to talk a lot about the data exchange, like DEQM, the implementation guideline from Da Vinci. We're going to talk about data flows from a provider to the payer, from the payer back to the provider, payer to measure authority, just all of the data flows, ongoing data challenges, and what's next. Um, so what's wrong with data flows for clinical quality measures? We could have a very long conversation about this, but if we look on the right-hand side of the screen, the way quality measures are calculated now is payers tend to grab data from all of the different locations that they can. They tend to throw it, like take an individual patient like Michael Westover, take all the data that they can, throw it at that individual patient and just see what sticks. So there's data that's keyed into web portals. We would love for those to go away, and they are going away. There's data coming from HIEs. There's non-standard supplemental clinical data that's being submitted. There's EHR, like chart pulls that are coming. I mean, there's CCDAs that are flowing. There are huge amounts of data that is flowing, and it is a massive, expensive industry right now. I mean, how much does our country spend on clinical quality measures these days? Something like $30 billion. Like it's a lot. Calculate them on the provider side, calculate them on the payer side with the the vendors that are calculating them, sharing the data, getting feedback. There's a lot that can be improved. Some of the issues, and these are just some, the data is often hidden and unusable in the dark corners of the EHR. Like you think the data is flowing, maybe just because you're using Fire, it should just work, but the data is not mapped appropriately. You have data transmission process, non-standard data transmission processes. Like for example, ECQMs and HEDIS use very different ways to share the quality data. The measure calculations are done at different steps in the process. Different parties are responsible at different points. There are onerous audit processes that don't necessarily improve the data at the source. There are inadequate feedback loops. So if we do identify an issue with the data, that issue that we've identified isn't changed at the source. So the same program problems continue to flow on an ongoing basis. And we could keep going, but we would love to solve all of these. So this is a quick overview, a very rough overview of how the data flows for clinical quality measures. Where it starts with is the measure authority. We're talking about HEDIS, so it would be NCQA, but that measure authority creates the measure definitions and the value sets, everything they would need to calculate the measure. And then that measure authority shares that information with the parties that need to know it. Like the measure calculation engine, they get the logic that they need from the measure authority and definitions. Also, a provider that needs to extract information from the EHR, like Providence, for example, we get the measure definitions, value sets, the logic that we need to pull data out of the EHR to share with payers. Like we look to the measure authority for that information. So after we know that, and I want to say that this grid is what we're going to use as we're going to follow this pathway step by step as we're going to talk through during this presentation. So the first thing that you need to do is the payer shares the population definition with the provider, like defines which patients or which members are we talking about. Um, and And then the provider will take that information and in some way, um, that provider will submit through the standard billing process or through supplemental data or through other means all of the data to the payer that the payer needs to calculate the quality measures. Then the payer takes all of the information from all of the provider organizations that contributed information to them. They take all of that information, they package it up, and they send it through to the measure calculation. It's often a vendor, a HEDIS vendor, right? Then that calculator will then share the patient level calculated measures with the payer. And then the payer will share the patient level calculated measures with each individual provider organization. And the payer shares the population level calculated measures with the measure authority, like NCQA in this case. So the payer's not sharing the patient level information, any PHI, personal health information. They're sharing the aggregate information with the measure authority. And this is the same with CMS. If you're sharing a QRDA3, for example, you're not sharing the patient level detail, you're sharing the calculated aggregate results. And if we look at the current state of how that data is shared, it is all over the place. So the current state is defining the population. It can be flat files, it can be Excel files to define that population to the provider. And then the way the provider shares information with the payer, it could be through supplemental clinical data, through flat files, CCDAs, chart pulls, various different formats. I've heard of payers that are accepting hundreds of different formats from different provider organizations. I know my team from Providence produces many formats for different payers for this purpose. And then the information that goes to the HEDIS engine or the engine that's calculating the measure, that's often shared in proprietary formats as well. Right now, the HEDIS engines, I don't think any of them accept FHIR. We really, really want them to if there are any on the line. And then they produce a proprietary format, that's numerator, denominator at the patient level, and supplemental clinical information. They share that back with the payer. And then sometimes the payer shares the information, like the gaps on how folks are performing on clinical quality, shares in these ugly multi-tabbed Excel spreadsheets that might work really well if you're like a care manager on the front lines doing outreach using that Excel spreadsheet, but it's not a true way to do interoperability or exchange this type of data at scale using standards. And oftentimes that information is not even sent back to the provider organization to show which gaps there are. And then when it comes to NCQA, for example, if we're talking about HEDIS, the data that is shared with NCQA is in an IDSS format. So this isn't all of what's happening in data exchange related to quality, but it can give you a sense of the current state of how data is exchanged. And because it's all over the place, because there's so many different formats that are used, like this creates a barrier and expense and difficulty for us to do this at scale. And also creates a barrier for patients in situations where the payers have one understanding of how quality is going with the patient, with their member populations. And then the providers on the front lines, because they have a different data set, different access to different data, and it takes a long time for data to get to them, they have a different understanding of the quality measure perspective for patients that they're treating. And then it's creates conflicts between the payer and the provider, and there's just a lot of opportunity for us to do this better. Are there any questions that have come up? Things folks would like to ask? And now I'll transition over to Linda Michaelsen.
Hey, good afternoon. So many years ago, this was one of the first projects of DaVinci, was creating this implementation guide that's called the Data Exchange for Quality Measures. And we did it specifically around medication reconciliation, which was a big problem with quality back around 2018. So this was defined, and it uses the clinical reasoning module of FHIR, and it is based on having a measure, like Michael said, that's defined by the authority, and they say what data is needed for each measure, for what period of time, what code sets, etc. And then in this guide, we tell you how to report that once you have a measure, and this is how you report that data. So there's 4 functions that are available. There are actually a few others, but these are the ones we'll focus on today. there's a profile in the DEQM called Data Exchange, and it's on the measure report. So it is the measure report fire resource, and then you tell it who the patient is, what the measure is, and you can attach the data or point to the data that you want to be exchanged specifically for that measure. And then there's an individual measure report. On the individual measure report, that's like today is QRDA1, and that has the individual patient and can have the related data. The big difference here is it calculates the measure for that individual. The data exchange does not. It just says here's data related to this measure for this patient. The third profile is summary, and that's like Michael said, what goes ultimately back to the measure authority or our measuring organization, and it is similar to a QRDA3. No patient information is included, just the summary information with the overall scores, numerator, denominator, exclusions, etc. Lastly, we defined a gaps in care report, which makes use of the measure report and can tell the provider what care is missing for a particular patient. So the metadata about it pointed to in the measure report tells you about what is included in the measure, like Michael said, value sets, data, etc. And then it can all be bundled up, and I use the word bundle, which is probably inappropriate. We want to talk about as container because it doesn't have to be a fire bundle, and can be sent used depending upon which direction we're going. So to that end, Michael, the next slide. So we talked about this workflow, and we're going to keep talking about it through the presentation today. I mentioned the measure authority that's created by the measure authority. And then Michael mentioned describing the payer population. And that can be done in a number of ways in FHIR. You can use it as the coverage, coverage by a particular entity. But the most common way, especially that's used in value-based care, is a population is defined for use by an organization or a provider group. And in FHIR speak, we have an IG for that called the ATR, Attribution IG, which lets you define a group of patients that belong to a particular provider. That is created by the payer and then shared with the provider. The provider, based on that list of patients, can then gather all of the FHIR data they have that relates to that particular measure for those patients and sending it using the Data Exchange for Quality Measures Data Exchange Profile. Remembering, this is just the patient and the data that it's pointing to for a particular measure. It does not include any calculations. Then the payer shares, like Michael said, all of these FHIR resources that came in through the Data Exchange for Quality Measures from all of the providers, and they gather it and push it to their engine. And also, like Michael said, we would love for that to use FHIR because it can. There's something called a CQL engine that can take FHIR in natively, take in these measures with the measure contains something called CQL, clinical quality language, that tells them how to calculate that measure. So all the data can be calculated directly from FHIR in a fully FHIR format. Next slide. So we talk about the DEQM Data Exchange Measure Report. This is the one that the provider would create, and they will create a FHIR container which contains all the underlying data for the quality measures. We use the word container here, but it could be done using bulk FHIR. It could be done with a bundle, depending upon how big the data is, etc. We're just referring to it as a container, not to influence that decision. Additionally, there can be a data exchange for quality measures data exchange measure report. So the data exchange measure report, or more, there can be many of these data exchange measure reports that points to the appropriate data in the data container that relates to the measure. And this measure report, like we said earlier, it contains the status, is the report complete? It points to the canonical for the measure. So you're both talking about a very specific measure. And the subject is the patient. It specifies the measurement period you're reporting for, also the date the report was generated, and then the reporting organization that submitted the data. And last but not least, it has the links to the FHIR container. One point I want to make here is, let's say you have 10 quality measures you're reporting on. So you have 10 data exchange measure reports here. All of those will need to point to the patient. So the patient is not in the container 10 times, it's in there once. And each exchange measure report points to that same patient. The same is true for any other data that might be redundant, like an encounter, if an encounter is applicable for a particular measure. So your FHIR container can be used many by the different data exchange measure reports. Next slide, Michael. So we've talked about options for what is in that FHIR container. And the three options that, like Michael said, are being discussed right now in the health tech ecosystem are the ones we list here. One is simply sending a FHIR container with only the relevant measure data. So you have 5 measures. Those 5 measures require you to submit certain observations, certain labs, certain, should have said labs are observations, certain conditions, etc. So you would submit all of that data, but it would not contain the measure report. So the pros to this is it's the simplest option for providers to implement, and it's currently in production with a few organizations. Some people are calling this CDEX, probably incorrectly, as we pointed out in several of the calls we've been having lately. But this is really just a package of FHIR data, FHIR container. The problem with it is there's uncertainty around what measures you're actually reporting for what period of time, even the ability to say this data is from March to June. You don't have that if you're simply sending a bunch of FHIR data in a container. Now, the FHIR container can also include the second option, which has those data exchange measure reports. The pros are obviously that it tells you what data you're reporting on. And an important point here is because you have this extra FHIR resource, which is a minimal, it's a very small resource for those of you who think about those things, it can be ignored by the payer. So you could start with a FHIR container and exchange it with the payer, and then over time want to have some better understanding of it and add that to your bundle. But payers can adopt it as they have time, or can do something with that in their workflow. They can get it and just ignore it when they receive it, but still process all the data. There are really one that we are aware of using this in the real world today. So maybe there are few examples of it, but we weren't aware of any. And then the last discussion is around why not just send all of US CDI, all of the data that's available through the G10 APIs that the EMRs have to support. It's nice because you could imagine it could be done with one comprehensive pull of all of the data, and it could be used for many reasons by the payer. But there are some cons to it. The file size could be enormous, as you can imagine. There can be data in there that are not used for any quality measures, potentially not even used for anything else that a payer might be interested in. And the older data may not be included. So you may not have the 10-year-old colonoscopies that you need for the colorectal cancer screening in this scenario, because that data is not defined. And the QA on it might be harder than if you had a more targeted data set. Because and you all know this if you receive CCDAs today, sometimes the problems in the CCDAs are in sections or portions that you have no interest in or use for in your processing, but they still cause a problem because they're there. You have to be able to at least process them and get them out of the way. So those are the three options. And there's still great discussion around this in the health tech ecosystem. They haven't landed on one. So I don't think we're ready to declare one here today, Michael. But if you go on to the next slide, I believe this is where my friend, I'm sorry, is this Anne where you jump in?
No, not yet.
All
No,
right.
yeah,
Well, then I'll
you're still
keep
on.
going.
You're still
This
on.
this is where the two other data exchange profiles are used. After the fire data all comes in on these exchange reports, goes into the engine. We're all using CQL and fire, and we're going to do that calculation. Then from that, a CQL engine can take the information connected to the measure, calculate it, and produce the individual measure reports. And those individual measure reports would contain for a particular patient, are they in the numerator, are they in the denominator, and more importantly, I guess, are they in a numerator or an exclusion? And then those can be sent on to the provider, and they can be wrapped in a gaps in care report, which even contains more information. It can give you insight, like guidance on what you might need to do to close that gap. So now, Anne,
Right.
oh, I'm sorry, still not Anne.
Still, you're
Um,
still a couple more after this. Yeah.
DEQM, I can't see slide numbers. The DEQM individual measure report is what we had said earlier. It's a fire measure report, and it points to data in the underlying container under what we call evaluated resources. So when we got the measure, it said, for this measure, I need the patient because I need to know their age or perhaps their gender. I need to know they had an encounter because that's required. I need A1C if we're using a measure that's A1C, so it'd be an observation with the A1C appropriate link codes, et cetera. All that is the evaluated resources. Additionally, it points to the patient, and like we said earlier, it points to the measure period, the report date, and so it gives you an idea of all of this information. But this time you do get the initial population, the denominator, the numerator, and any exclusions. So that's why it's especially useful to go back to the provider. And there are considerations for data flow in this around where do you start? And we talked about that a little earlier. You can consider starting with the individual measure reports, and it would allow the provider to see those individual patients and if they've met the numerator denominator. As you mature, you might want to add your own fire container, being the payer, add your own fire container with all the data that you have that supports that measure report. It is quite likely that the payers receiving this individual measure report may not have all of the same data that the payer does. The example I always use for that is mammograms. Patients can self-order a mammogram, go to any, screening mammogram site that's a site on wheels, or make an appointment, and the payer will know about that because they paid for the mammogram, but it may not be in the provider system. So they can include those details, and that will help the providers give better care to the patients as they see them, and not keep asking me, like my provider does, who isn't connected, when are you going to get this done? I got it done, and then I get scheduled to make an appointment for one, and so on and so forth. So it's a good thing for the patient to, exchange that data. So down below, we just talk about the three potential reports that could be given to the provider in this sort of state of ultimate state. We talked about, initially they could give them the individual measure report. They could add the fire container. Ultimately, they could give them the summary. If they are at risk, if you're in a value-based contract where they're at risk, it's probably beneficial to give them that summary measure report. You likely give it to them today, although not in this format. And then there is that better format of the gaps in care report, which includes not only the individual measure reports, but it gives you additional fire resources, one called the detected issue, and it can also give you guidance. So that guidance resource would allow you to say to the provider, we need a observation with this link code on it, or we need a condition of, in our value, in this value set. It allows you to exchange that more detailed data when you get to that fully implemented scope.
Okay, now I'll pick up, Linda.
Thank you.
Okay, so I've got the last step, the transfer of information from the payer to the measure authority. And as Michael said previously, we currently, NCQA uses its own proprietary format. It's called an IDSS format. IDSS stands for Interactive Data Submission System. So it was a system we built many, many years ago to collect the data. It started off with payers entering information by hand, and it has grown to now accept a proprietary XML format. And it's very specific to our system because our measures have multiple data collection types. So we collect data that has been run electronically, but we also collect data that's been collected by hand by a manual abstraction process. So to try and get all that data rolled up into one report, we have our own format. We have been exploring DEQM measure, using DEQM measure report, and you can see that's on here as the direction we want to go, and NCQA has been exploring that. We have some data elements beyond what CMS asks for in their measure reports. But the biggest challenge for us right now is those hybrid measures. So a summary measure report works really well when all the data is flowing in electronically and you can calculate that measure report electronically. But like I said, with our hybrid methodology right now, we also have manual data to add in there. So that makes it a little bit harder to kind of get all the information into one comprehensive report. So right now we have a projected timeline, and some of you may have seen this. We have a projected timeline for retiring our hybrid methodology around measurement year 2029. So how and when we start accepting fire-based reporting submissions may hinge a little bit on that. Next slide. So our current IDSS format basically equates to a DEQM summary format. It captures calculated quality measures at the population level. So it's designed to look at things like the initial population, the denominator, the numerator, the number of exclusions you've had, and provide that summary information. DEQM provides the same information in more of a standards-based format for that summary data. And depending on who's collecting the data, the payload may include records that were evaluated to calculate the measures. That is an option. As NCQA, we would probably not want that PHI, that protected health information. So we would collect something that looks similar to our collection methodology right now, which is just the summary population information. So just to kind of walk into the details a little bit, the way our IDSS submission works is that you currently upload an XML file, and we provide an interface so that health plans and auditors can review that information you've uploaded. So we want them to be able to make sure that that information is correct before they submit it to us. So they can look at it on the screen, make sure it's what they anticipated showing up, and before they actually hit the submit button to submit to us. We would probably maintain that same model moving forward into a DQM summary measure report. So you would upload a summary measure report. You'd be able to view that information on the screen so the auditor could check that it was indeed the information that they approved for submission before that information was submitted to us. And then providing that information back to providers. So right now, I think there's a lot of methodologies, like Michael said, in terms of providing the information back to from payers back to providers, to the organizations that contributed the data for their measures. Right now, I know that some of the HEDIS vendors in the current world, some of the HEDIS vendors do create gap reports that they share with the health plans, and then the health plans can choose to share that information with their providers or choose not to. We know that there are health plans doing education, doing direct outreach to patients and kind of skipping over the provider and going straight to the patient and letting them know that they have a care gap that needs to be closed. So there's a lot of different methodologies in here right now, and it would be nice if we could standardize that so that NCQA was out of that loop, first of all, because we only have the summary data. So there's no way for us to provide information back to the payers or to the organizations that support it. But we would like to see the payers provide that information back. And as Linda said, use like a care gap report or something like that to be able to enhance the care of the patient. Because reporting to us shows everybody what the rates are, but getting the information back to the point of care is really what's going to drive care. Next slide. All right, ongoing data challenges to talk a little bit about what does this data look like and how hard is it to get back and forth. So we know that people have been working on bulk fire. We know that that standard has some work that needs to be done on it, yet it's not quite a finished standard. We know that EHRs have cutoffs for large populations. I've heard of EHRs that will cut off at 1,000 patients, and you will then have to submit another request for another set of patients. So there's all kinds of ways right now that that it makes it hard for an organization who wants to calculate quality measures to be able to get the information they need to do that. We really need to work on address this as an industry to ensure that everybody has access to the data they need when they need it. We also have some data that is not readily available in FHIR or through FHIR endpoints. So for instance, we have things like Category 2 CPT codes. These codes are added at the time of billing, so they may not be available in an EHR. They were originally designed to be used by a provider to let a payer organization know that a particular patient met a particular quality measure. So for instance, there's CPT level, category 2 level codes for HbA1c greater than 9 or less than 7. So the provider can attach those codes. They're not actually any care that the provider's given, but there's sort of an attestation from the provider to the health plan that this is the level of HbA1c that this patient has. So they're not frequently not included in the services that are provided to the patient, but they're attached later at the time of billing, maybe when a lab comes back and you can say, oh, I see this person's level is this. I'm going to attach this level 2 code to the claim. So some of this information just isn't even available at the time of the service. We have also many different layouts, like Linda pointed out earlier. and Michael, we have US CDI, we have DEQM, we have CDEX, we have a whole bunch of different standards. So which one of these standards are you going to use for your transfer? Is it going to be a push or a pull? What's going to initiate that transfer, right? So again, there's a whole bunch of different decisions you have to make around that transfer. And right now, the industry isn't centered on any one particular place. We're really trying to push the industry to say, what standard can everybody use? Another challenge we have is the measure calculation engines themselves. So that bottom line on the graph that we've been following may be a particular HEDIS vendor that a health plan is using to calculate their HEDIS report. So right now, what we have with those vendors is they have been around for a long time. They all have tech stacks that they've built over the last 30 years for HEDIS reporting. Those tech stacks rely on a lot of different information coming in, probably in a proprietary format. And those vendors also have a lot of different measures they run. So maybe they run HEDIS measures, maybe they run state-specific measures, maybe they run measures for their individual clients who are looking to do quality improvement, right? So these vendors have not brought their systems up to calculating or consuming fire-based, any kind of fire-based standard. Some of them don't have an import for fire-based data. They're still using their proprietary format. Some of them have not converted their tech stacks over to run digital quality measures yet. And many of them are producing information that goes into their proprietary formats that you can use in your proprietary tool to view your results. So all of that has a proprietary flow to it as well. So many of these HEDIS vendors just aren't there yet. They haven't taken the time to they haven't taken the time to convert. They haven't decided that it's cost effective to convert yet because, well, maybe they can run digital HEDIS measures because we've digitalized our data set. States and other entities, specialty association things maybe have not digitalized their measures yet. So a vendor is stuck in this position of, well, I could run these measures digitally, but I would have to go back to my old system for these measures. So there's a lot of complex decisions in there for those vendors. And then lastly, we have the challenge of data mapping, and we've seen this because we do, as Michael said, onerous audits. We do audits for the HEDIS measures, and the auditors have to go back to the primary source for some of the data streams that are coming into a health plan. And so we've seen things like codes that are mapped incorrectly coming out of the EHR. So the EHR will prepare a feed that will go to the health plan, and that feed will say have flexible sigmoidoscopies that are mapped to colonoscopy codes. And then our auditors find that as they go back to the primary source and they see that the person had a flexible sigmoidoscopy and not a colonoscopy. We've also seen where EHR vendors have incorrectly taken schedule events from their scheduled tables rather and reported them as events that have been completed, procedures that have been completed. So there's a lot of inconsistency in the data yet, even as it's coming out of the EHR. Next slide. So I wanted to take a minute and talk about some of the data gaps in another perspective. So we have US CDI, and we've been talking about US CDI quite a bit. There's this thing called US CDI plus 10 I wanted to talk about for just a minute. So if you're pulling US CDI data straight, you may not be getting everything you need for quality measures. Or for a particular quality measure. There is a need for quality measures that go beyond things that are in US CDI. And Levitt Partners did an analysis and they found that there are 10 key elements that go above and beyond US CDI that could enhance people's ability to report quality measures. If we had these 10 elements, we could, in addition to US CDI, we could come closer to being able to report quality measures. Next slide.
And just one
Yeah.
comment. These 10 are for ECQMs particularly, right? They're not
Yep.
covered in this. Yeah.
Yes, that's a good point. These 10 are
Yeah.
not necessarily for HEDIS. They did this analysis on ECQMs. And the other thing I would say in addition to that, Michael, is some of them are on the hospital side. So it also depends on whether you're doing hospital measures or outpatient measures. Things like medication administration affect almost every hospital measure. Okay, next slide. And then I wanted to kind of bring the pieces together around because there's a lot of IGs out there. We've been talking about different things. So I just want to bring all the pieces together. So we have US Core, which is off of it's basically the implementation guide for US CDI. So US CDI is published. That's what ONC puts out there as the data elements that are of interest. From that, we create US Core, which is the implementation of those US CDI data elements. And that sounds like it should be really big, but it's really the smallest thing because then when you go to calculate quality measures, you need to, like I said, with the 10 examples on the previous page, you need to add to that to be able to get to the place where you can calculate quality measures. So one size bigger than that is the quality core IG, which really gives you the quality data elements and resources you need for the ECQMs. And then one bigger than that is QI core. It's a little more comprehensive. It has some additional requirements beyond quality core, US quality core. So you can see these things build off of each other as they move up. And I think
There's one more.
I have one more, yes.
Yeah.
So we've been talking about IGs, we've been talking about quality data elements, but I just want to bring it back to a measure for a minute. When we come back to a measure, you're not going to need everything that's in US CDI for one measure. You're not going to need everything that's in US quality core for one measure. You're not going to need everything that's in QI core for one measure, right? So how do you know what you need for a measure or a set of measures that you're working with? So really what you want to do is you want to bring it back to, here's the set of measures I'm working with. Now I can go and look at the libraries associated with those measures and come up with the data requirements for those measures. So even a set of measures isn't going to use all of US CDI or all of US quality core. It's going to use pieces of it. So you want to make sure that you're really interrogating the set of measures that you're interested in and making sure that you're picking up the data requirements for those measures because it may be a smaller set and you may have good data for those measures, whereas maybe you don't have good data in all of US CDI. Okay, and I will turn it back to Michael.
Great. So if you're going to screen capture one, we're happy to share all of this in slides, and I know the video is getting posted, but this gives an overview of the future state of where we are going with clinical quality data and how we're supporting the data flows for clinical quality measures. There's ATR to define a population and DEQM Data Exchange Report to share the underlying data needed to calculate the measures, and then individual measure reports for the calculated stuff, and then summary reports to go to the measure authorities. And of course, there's the gap list, which can be added to supplement some of this stuff too. So you can see how we could ideally, wouldn't it be amazing if we could move away from that place of multi-tabbed, ugly Excel spreadsheets and different proprietary standards to use the standards that are created specifically to do this work. And I know that there are some organizations like Providence that are, consuming ATR in production. We're producing the fire container data and sharing with payers using the national standard that's used in clinical quality measures. And I think there's a lot of exciting progress that's happening in this front. I think the front half of this, if we divided this slide in half, the front half, I think there's some movement in using standards. And then the back half, I think it makes sense to start at the beginning. And then, after the payers have the data in the national standard, be able to produce gap lists and things like that using standards to send back to providers. So we're coming to the end. What's next is another side we could talk a lot about, but the health tech ecosystem groups are talking right now about what clinical data exchange should look like. I know we just had a robust, energetic discussion between payers and providers just this morning about how this data should be exchanged. I'm using some of the frameworks that we talked about today. And so we'll see where where groups just decide on how the data should be exchanged. I think some groups were saying, we should just take all of US CDI, all of the data and just share it with payers for all the patient populations. And then we can do quality measures and other things that we want to do, risk profiling and care management and all the things we need to do with one data set. And then there are folks that say, well, no, what if I just want the data for clinical quality measures? For quality measures, can I just use the measure authority to get the value sets and the data definitions to just pull the minimum necessary that we need? And around we go. That likely we're going to need both. So then NCQA, I think, made an exciting commitment. I don't know if Ann wants to add anything more about this, but committed to changing how the auditing process works in 2026 to reduce burden along the way.
Yeah, I'll just say I talked about primary source verification PSV. We've made a commitment to start reducing the amount of PSV that's being done.
Excellent. All right. I think there are questions still about the best way to get data out of the HRs at scale. There are a bunch of initiatives. We have TEFCA, CMS-aligned networks. We have payer platforms. We have data that's pulled out through the G10 APIs. Like there are a bunch of ways to get data out. And I don't think this is maybe there one way will kind of rise up over time to be the best way to get data out at scale. But I feel like it's going to be a combination of these things as we're learning. And honestly, some of these ways to pull data out of the EHRs are, using some of the same ways that like a provider organization would use to pull data out of the HR as well. So we'll see how that evolves. But I feel like there's an absolute need for organizations to be able to get data out of the HRs at scale, using bulk FHIR or being able to use the platforms and TEFCA in these different ways. We need to be able to get this data out. Like my team, for example, pulls data for clinical quality measures for over 800,000 lives right now for our different contracts. And we just expect that to grow over time. I think there's a request for the measure authorities to publish their measure definitions through an API that we can reference. So instead of like taking a PDF document or Excel spreadsheet that has measure definitions, wouldn't it be amazing if we could just, query the measure definition in real time, like through a URL, to pull what we need to calculate the measures? I think that doesn't exist today, but I think it would be an exciting direction that we can go. And then again, I know we talked about it before, but the data mapping issues before the data leaves the EHR, even if we have, let's say, APIs set up that are compliant with the standards, how the data is mapped to those APIs might not be working effectively. And maybe the data is still hidden in the secret corners of the EHR or some binary file that's hard to get the information out. That's the kind of thing where a continuous feedback loop could improve the data over time. I feel like this isn't just creating the standard isn't going to solve this. It's going to take work through the EHRs, through the providers, through the HEDIS engines, like everyone along the line to make this all work better. And those that do a good job with that feedback loop and continuously improving the data, I feel like are going to win in the long run on quality. I saw that there were some questions, but I'm not able to see them on the screen because I'm projecting right now. Were there any questions that came up that we should address or questions that folks have?
I have some questions. I think along the lines of the DEQM specification, how are we thinking about the ask to the EHR here? Because there's some ask we're making in order to comply with this specification versus the US CDI, standard FHIR R4 resources. Is that more important or less important than, say, the bulk FHIR support? And how are we prioritizing? Like, what do you all see as the path forward to actually making this a reality in the future? And how do we achieve a low friction path, or are we going the route of CEHRT updates?
I think this is a core question that is very, very important to make this work. One of the benefits is some of the things you just said, it's the same resources, right? It's all like if I'm thinking about Epic, it would be, the US CDI APIs that they have is a big chunk of the information that we would need to pull for this. And you could pull that data in bulk, or you could put for each individual patient, like patient by patient, resource by resource, but it's the same set of standard resources. I think that it is absolutely important that we continue to push EHRs to support data exchange at scale. I know that my team just pulling for 800,000 lives once a month, clinical quality measures using those G10 APIs, measure by measure, patient by patient. We are putting some stress on our EHR environment today. I've had some angry telephone calls with folks inside of my organization and Epic saying like, you haven't impacted production, but you're getting close to impacting production. So I feel like the networks that are going to connect to the EHR are going to be pulling the data through similar pathways. So we need to be able to push the EHRs. I feel like many of them are still using like their if you're trying to pull data using Fire out of the HRs, it's being pulled out of their production environments instead of being carved out into a location that's like pre-packaged Fire, pre-aggregated that's built to exchange Fire at scale. Some that are still reaching into their production environments that are built on like non-Fire databases and trying to pull that information in memory for each of the patients, and that tends to slow things down. So I think advocating for our EHRs to be able to exchange the data needed for quality measures at scale is the biggest risk factor that we have right now. So bulk Fire, getting that to work. I don't know if other folks have opinions on this topic.
It's US CDI or just the quality measures, bulk data is going to have to be used. So I agree with you, Michael.
Mm-hmm.
Well, what about support for the other measure specifications, right? Or, I'm sorry, the Fire resources that are included in this spec, right? We're talking about actually generating unique Fire resources to support the DEQM spec, and so how do we see the deployment of that? So I understand the scale topic, absolutely, but are we going to ask for this to be incorporated into a US CDI, or is this something that we think that EHRs will adopt because it provides enough value?
I mean, a vast majority of the data that we need is already in USCDI and is in the resources. I think we talked about that USCDI plus 10. And I think the idea is that we're trying to get as much information into CDI, USCDI or USCDI
Uh,
plus quality to do
I'm
this.
asking about the measure report Fire resource. So like the
Oh,
specific Fire resources that are not currently in, supported by anybody today.
yeah. That's a good question. And that's why one of the options was you could just provide the raw data, that's defined by the measure report without the DEQM, like defining what goes along with it. But does it make sense to try to get the AHRs to build that DEQM into? I think so, but I wouldn't say it's it's not absolutely necessary. Like it's not like a do or die kind of thing.
Well, that's good because I'd love to see
Yeah.
adoption of this without putting arbitrary technical blockers in front of us, right? Or maybe not arbitrary, but at the same time, it's a technical blocker that maybe we don't need.
Yeah, exactly. And that's why what's in prod today, I know that few organizations like Providence can produce that Fire container that has all the data you need without the DEQM on top of it. I imagine like that's the same, you could do that on top of any HR today as well.
This is Yan. I just want to chime in here. So DEQM, the version that is going to ballot in May, that one actually is moving from US realm to universal realm. So it's not dependent on any data model. So the current version that is actually using depend on QI core in certain version. But this one is currently in the ballot for everybody to review. That is, you can plug in like a US core data model. You can plug in US quality core. So it's not just constrained to, like there's no DEQM specific data model. That's what I'm trying to say.
Yeah, it's the measure there. You could actually have a payer that defines their own quality measure data model, right? That could be used too, right? It could be homegrown
EQ. Yeah.
with DEQM.
Well, we are at time, but what an amazing presentation. I really enjoyed that today. I want to thank you. And I want to thank everyone for joining us and thank Michael and Linda and Anne for presenting. And yes, if you can send me a copy of those slides to add to the minutes, we would really appreciate it. Thanks again.
Thank you.
Well, thanks everyone.
Have a wonderful Thursday.